Okay, let's unpack this.
Hmm.
Picture this. A patient sits in front of you, describing a sudden, alarming loss of vision in one eye. It was like a curtain coming down, they say, or maybe a shade being pulled.
Mm-hmm.
But then, just as quickly as it started, it resolved completely. Transient unilateral blindness, Amaurosis Fugax. It's, a fleeting symptom, yes, but it carries a heavy weight.
It really does.
It's a well-known warning sign, a critical signal that a stroke might be imminent. The urgency couldn't be clearer.
Absolutely.
That's precisely why our deep dive today is into a very specific, highly structured pathway designed to tackle this urgent clinical scenario.
Yeah.
The Amaurosis Fugax Management Protocol 2025.
Exactly. And the source document, it lays out this protocol with really a singular focus to provide a rapid, comprehensive, and evidence-based pathway.
Right.
The objective is twofold and honestly critical for the patient: to minimize the risk of permanent vision loss from a completed ophthalmic stroke, and probably even more importantly, to prevent a debilitating cerebral stroke. And this isn't just a set of loose recommendations. The source frames this as a clear, structured approach tailored specifically for you, the specialist clinician who will be, receiving and managing these patients.
And our mission today is to walk through this protocol just as it's presented in the document, extracting the most vital, actionable details. We'll start right at the very beginning, the precise point when the protocol is triggered, how that critical initial diagnosis is made, and the immediate triage.
Okay.
From there, we'll dive deep into the mandated urgent diagnostic workup, exploring each required investigation, including the crucial role and, the timing of imaging.
Yes, timing is key.
Then we'll shift to the clinical management pathways, which are fundamentally determined by the findings of that initial workup, particularly the vascular assessment. A significant portion of our time will be spent dissecting the optimal medical therapy component, which the source highlights as including some specific updates.
Very important updates there.
We'll cover the essential multidisciplinary collaboration required, detail the structured follow-up schedules based on management, and finally, get into the practical necessities, the referral logistics, who to contact, where investigations happen, and how patient data is managed within this specific framework as outlined in a memorandum of understanding. It's a significant amount of ground to cover, but each piece is vital for anyone involved in the care of these, high-risk patients.
And our aim throughout this deep dive is really to synthesize the key information, the practical steps, and the specific nuances and updates from this particular protocol document, delivering the insights you need to understand and potentially apply this framework in your own clinical setting. It's about getting to grips with this specific standardized approach.
So let's jump right in at the start gate, section 1, initial diagnosis and triage. The protocol is very precise about what initiates this pathway. It doesn't begin with just any transient visual symptom. It starts with a specific clinical event and a specific clinician's assessment.
Precisely. The very first step, the trigger point for engaging this entire structured protocol, is explicitly defined as an accurate clinical diagnosis of Amaurosis Fugax. And importantly, this diagnosis must be made by a qualified ophthalmologist.
Okay, so it has to be the ophthalmologist.
Yes. This isn't something that bypasses the eye specialist. The protocol recognizes that the ophthalmologist, often being the first point of contact for acute visual symptoms, is uniquely positioned to correctly identify this particular critical presentation.
Right.
Their clinical expertise and ophthalmic assessment makes them the necessary gatekeeper for entry into this specific accelerated management pathway.
And how is that diagnosis typically established by the ophthalmologist, according to the source? What does that initial assessment involve?
Well, the source specifies that the diagnosis is typically made via fundoscopic assessment performed on a patient presenting with a classic history of acute transient unilateral blindness.
Okay, the history.
Yeah, think of the history. A sudden, often dramatic loss of vision in one eye that lasts for, maybe a period of minutes to perhaps an hour or two, and then recovers spontaneously. This acute, transient, and unilateral nature is the hallmark symptom.
Got it.
The ophthalmologist's role involves taking this detailed history and performing a fundoscopic examination, looking at the back of the eye. Now, while fundoscopy might sometimes reveal visible emboli in the retinal vessels or other signs of vascular compromise,
Right, you might see something.
you might, but the diagnosis of Amaurosis Fugax itself is fundamentally a clinical diagnosis based on that characteristic transient visual symptom and the exclusion of other obvious ophthalmic causes on examination.
Okay.
The transient nature is the critical differentiator. It's a symptom that resolves, but its very transience makes it such a red flag for underlying systemic vascular disease, particularly things like carotid artery disease or a cardiac source, which could lead to more permanent, devastating events like stroke.
So, the entire structured pathway is initiated when a qualified ophthalmologist encounters that characteristic patient history and performs their initial assessment, specifically the fundoscopy, leading to that accurate clinical diagnosis of Amaurosis Fugax.
Yes.
That initial step by the ophthalmic specialist is the indispensable starting point that opens the door to everything that follows in this protocol.
Okay, so just to quickly recap Section 1 then. This protocol is initiated when a qualified ophthalmologist makes an accurate clinical diagnosis of Amaurosis Fugax. This diagnosis is typically based on a patient reporting acute, transient unilateral blindness and is supported by an initial fundoscopic assessment. This specific clinical step by the ophthalmic specialist is the formal trigger for the subsequent urgent management pathway outlined in the protocol.
All right, once that crucial initial diagnosis is made by the ophthalmologist, the very next step is immediate action. Getting the right test done right away is paramount. And Section 2 tells us exactly what those are. It outlines the immediate diagnostic workup, and the word immediate here is not really open to interpretation.
Absolutely. The urgency is not negotiable in this protocol. The source mandates that these initial diagnostic investigations must be performed urgently with a clear target, ideally on the same day as presentation.
Same day? Wow.
Yes. This emphasis on same-day evaluation reflects the understanding that Amaurosis Fugax is a powerful predictor of very early stroke risk. Any delays in identifying the underlying cause can translate directly into missed opportunities for stroke prevention.
So what are the absolute core components of this urgent same-day workup that the protocol requires?
Okay, the protocol lists 3 primary areas of urgent investigation that form the foundation of this immediate assessment, plus a necessary risk assessment step.
3 areas plus risk assessment.
First, and often the most fruitful investigation for these patients, is vascular imaging. The protocol requires an urgent carotid duplex Doppler ultrasound.
A carotid scan.
Yes, exactly. This test is crucial for assessing the internal carotid arteries, particularly the one on the same side as the affected eye, the ipsilateral carotid artery. The goal is to identify and quantify any atherosclerotic stenosis, which is, a narrowing of the artery caused by plaque buildup.
Right.
Severe carotid stenosis is a leading cause of Amaurosis Fugax and ischemic stroke, and identifying it is critical because it's often treatable with surgery or stenting. Determining the presence and degree of stenosis urgently is really a cornerstone of this protocol.
Makes sense. What's second?
Second, there's cardiac evaluation. A 12-lead electrocardiogram, or ECG, is explicitly mandated as part of this immediate workup.
An ECG mandatory.
Mandatory. The primary purpose of the ECG in this context is to screen for potential cardiac sources of emboli, most notably atrial fibrillation. Atrial fibrillation is, as you know, an irregular heart rhythm that can lead to the formation of blood clots within the heart chambers. These clots can then dislodge and travel to the brain, or, importantly for Amaurosis Fugax, to the ophthalmic artery, causing blockage and ischemic symptoms. Rapidly identifying atrial fibrillation or other significant arrhythmias is essential because they require specific anticoagulation therapy to prevent future embolic events.
Okay, vascular cardiac. What's the third area?
Third, the protocol specifies inflammatory markers. Now, this investigation is triggered by patient age. For patients over 50 years of age, blood tests for erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP, are required.
Over 50 only?
Yes, specifically over 50. This is a vital screen for giant cell arteritis, or GCA. GCA is a systemic vasculitis, an inflammation of blood vessels which preferentially affects medium and large arteries, including those supplying the eyes and brain.
Right, GCA.
It can cause symptoms ranging from headache and jaw pain to sudden, profound vision loss and stroke. Amaurosis Fugax can actually be a prodromal symptom of GCA. Because GCA requires prompt treatment with corticosteroids to prevent irreversible vision loss and stroke, and it's more common in individuals over 50, these blood tests are a mandatory urgent screen in that specified age group. Elevated ESR and CRP can raise suspicion and prompt further specific evaluation for GCA.
Okay, and you mentioned risk stratification too.
Yes. Finally, Section 2 also incorporates risk stratification. The source recommends the use of a validated risk score, specifically naming the ABCD2 score.
Ah, the ABCD2 score.
Exactly. This score takes into account factors like age, blood pressure, clinical features like unilateral weakness or speech disturbance, duration of symptoms, and presence of diabetes. Amaurosis Fugax is considered a type of transient ischemic attack affecting the eye. The ABCD2 score is a validated tool for predicting the short-term risk of subsequent stroke after a TIA. Calculating this score helps the clinician quantify the patient's immediate risk level, which can then inform the intensity and speed of further management decisions. It adds another layer of objective assessment to prioritize care for those at highest risk.
So this initial urgent workup is a triad focusing on vascular, cardiac, and inflammatory causes, performed with same-day urgency and supplemented by a validated stroke risk assessment tool. That's a lot to get done quickly.
It is. Okay, so to quickly summarize Section 2, the immediate diagnostic workup under this protocol requires urgent, ideally same-day investigations. These include a carotid duplex Doppler ultrasound to assess for internal carotid artery stenosis, a mandatory 12-lead ECG to screen for cardiac arrhythmias, like atrial fibrillation, and in patients 50 years of age or older, blood tests for ESR and CRP to screen for giant cell arteritis. Additionally, the validated ADCD2 score is recommended for risk stratification to help predict immediate stroke risk and guide subsequent management intensity.
Okay. Section 3 moves on to neuroimaging, specifically CT or MRI scans of the brain. The source points out that these are performed in selected patients. This tells us it's not a universal requirement for everyone who presents with amaurosis fugax, unlike, say, the urgent carotid ultrasound or ECG.
That is absolutely correct. The protocol is quite specific about when neuroimaging is necessary. It's reserved for situations where the clinical picture suggests broader neurological involvement or maybe alternative diagnoses or even established tissue damage, going beyond the typical isolated transient ophthalmic symptom.
So it's selective.
Selective, yes. The decision to obtain a brain CP or MRI is based on specific triggers identified during the initial assessment or workup.
What are those specific criteria or triggers listed in the source that would prompt a brain scan under this protocol?
Okay, the source outlines 3 key scenarios where neuroimaging is indicated.
3 triggers, got it.
The first trigger is the presence of concurrent transient hemiparesis or expressive dysphagia. Hemiparesis being temporary weakness on one side and expressive dysphagia, transient difficulty speaking.
Okay, so if they had other neurosymptoms with the vision loss.
Exactly. If the patient experienced these neurological symptoms at the same time as their Amaurosis Fugax episode, or if the transient event included both visual and these other neurological deficits, then brain imaging is required. While Amaurosis Fugax affects the ophthalmic circulation, hemiparesis or dysphagia point towards ischemia in brain regions supplied by the carotid artery.
Like the cerebral hemispheres.
Or potentially the vertebrobasilar system, yes.
Yeah.
Imaging the brain helps to confirm if there was a broader transient ischemic attack affecting other parts of the brain, or if there's evidence of prior or concurrent cerebral infarction, giving a more complete picture of the patient's vascular risk profile.
Okay, that makes sense. What's the second trigger?
The second trigger is atypical features or diagnostic uncertainty. Amaurosis Fugax usually follows a pretty classic pattern. If the patient's reported visual symptoms are unusual in their description, duration, or associated features, or if after the initial workup, the carotid scan, ECG, inflammatory markers, there's still significant doubt about whether the event was truly Amaurosis Fugax or what caused it, brain imaging can be helpful.
So if it just doesn't quite fit the mold.
Right. It allows clinicians to look for other potential causes of transient neurological symptoms or to confirm the absence of other intracranial pathology that might be mimicking vascular symptoms, although vascular causes remain the primary focus, of course.
And the third trigger?
The third trigger is evidence of retinal infarction on fundoscopy. As we mentioned, the ophthalmologist performs a fundoscopic exam initially. While Amaurosis Fugax is defined by transient vision loss, sometimes the embolic event causing the symptom can lead to permanent damage in the retina.
So actual damage seen in the eye exam.
Precisely. Visible on fundoscopy as a retinal infarction or maybe a branch or central retinal artery occlusion. The source states that if the ophthalmologist finds evidence of this retinal tissue damage during the fundoscopic exam, then brain imaging is necessary.
Why is that?
Well, the rationale here is that a completed stroke in the ophthalmic circulation, the retinal infarction, significantly increases the likelihood of finding concurrent or future ischemic events in the brain itself. It's kind of a marker of widespread arterial disease and warrants a look at the cerebral circulation.
Okay, just a brief recap of Section 3 on neuroimaging then. CT or MRI scans of the brain are not universal but are performed selectively under this protocol. The triggers for needing brain imaging are if the patient had concurrent transient neurological symptoms like weakness on one side or difficulty with speech, if the presentation is atypical or there's diagnostic uncertainty, or if the ophthalmologist finds evidence of actual retinal tissue damage or retinal infarction during the fundoscopic exam.
Right. Okay, let's maybe consolidate our understanding of this whole initial diagnostic and workup phase we've covered in the first 3 sections. It's quite a bit.
Yeah, let's do a mega recap of this block.
So the process begins with the ophthalmologist's accurate clinical diagnosis of amaurosis fugax based on that characteristic history of acute, transient unilateral blindness and their initial fundoscopic assessment. That diagnosis triggers the pathway.
Right, the trigger.
The protocol then mandates an immediate, urgent diagnostic workup, ideally completed on the same day. This workup includes a carotid duplex Doppler ultrasound to evaluate for internal carotid artery stenosis, a mandatory 12-lead ECG to screen for cardiac arrhythmias as a potential embolic source, and for patients aged 50 and over, blood tests for ESR and CRP to screen for giant cell arteritis.
The core triad.
Exactly. Alongside these investigations, the ABCD2 score is recommended for risk stratification to assess immediate stroke risk. Neuroimaging, using CT or MRI of the brain, is then a selective step. It is indicated only in specific circumstances. If the patient experienced concurrent transient neurological symptoms like hemiparesis or expressive dysphagia, if the clinical presentation is atypical or the diagnosis is uncertain, or if the ophthalmologist finds evidence of retinal infarction on fundoscopy. This entire initial phase is designed for rapid information gathering, quickly identifying the most probable underlying causes of the amaurosis fugax and assessing the immediate risk of a cerebral stroke.
Okay, let's apply what we've just covered in sections 1 through 3 with a quick clinical scenario, a board-style question, if you will.
Sounds good.
Imagine a 62-year-old patient presenting with a single 15-minute episode of complete loss of vision in their left eye that resolves spontaneously. They report no other symptoms. Fundoscopy is unremarkable. Their blood pressure is 155/92. They have a history of diet-controlled type 2 diabetes. Based specifically on the protocol outlined in sections 1 through 3, which of the following is the most appropriate next step today?
A. Schedule a non-urgent follow-up with neurology. B. Order an urgent carotid duplex Doppler ultrasound, 12-lead ECG, ESR, and CRP. Perform a brain MRI immediately. D. Reassure the patient that because the vision returned, no further workup is needed. Short plus.
Okay, let's think through the answer here. The patient has acute transient unilateral blindness diagnosed by an ophthalmologist, meeting the trigger criteria from section 1. They are 62, so over 50, and they have diabetes, which are relevant factors for risk in specific investigations. Section 2 mandates an immediate diagnostic workup, including carotid duplex Doppler, 12-lead ECG, and inflammatory markers, ESR-CRP, in patients over 50. So ESR-CRP are needed here.
Right, because they're over 50.
Correct. While the patient has diabetes, relevant for the ABCD2 score, the question asks about the next step today. Neuroimaging, CT-MRI, from Section 3 is selective and not indicated here as there are no concurrent neurological symptoms, no atypical features reported, and no retinal infarction found on fundoscopy.
So MRI is out for now.
Right. Reassurance, option D, is definitely incorrect given the high stroke risk associated with amaurosis fugax.
Absolutely not D.
Scheduling a non-urgent follow-up, option A, ignores the urgency mandated by the protocol.
Also wrong.
Therefore, based on the protocol, the most appropriate next step today is to order the urgent carotid duplex Doppler ultrasound, 12-lead ECG, and ESR and CRP because the patient is over 50. The correct answer is B.
B it is. Okay, all right, with that critical initial urgent workup completed, ideally all on the same day. Section 4 tells us how the clinical management pathway then unfolds. This section is fundamentally driven by the results of one of those key urgent tests, the carotid duplex Doppler ultrasound. This is really where the rubber meets the road in terms of potential interventions.
Absolutely. The degree of narrowing, or stenosis, found in the internal carotid artery on the side corresponding to the affected eye, the ipsilateral carotid artery, is the primary determinant for which management strategy the patient enters within this protocol. You can almost visualize this like a clear decision flowchart derived from the ultrasound results.
Okay, let's visualize that flowchart step by step based on the source. Walk us through it.
Right. So once the carotid duplex Doppler report is available, the first critical decision point is based on high-grade stenosis. The protocol asks, is the ipsilateral internal carotid artery stenosis 70% or greater? This represents severe narrowing.
70% or more. Okay.
If the answer is yes, the source specifies 2 key actions. First, this patient is considered a candidate for a carotid endarterectomy.
Surgery consideration.
Exactly. This refers them down a pathway towards potential surgical intervention. Carotid endarterectomy is a procedure performed by vascular surgeons to remove the atherosclerotic plaque causing the significant narrowing, and there's strong evidence supporting its benefit in reducing stroke risk in symptomatic patients with high-grade stenosis.
Got it. And the second action?
Second, and this is crucial for timing, regardless of the consideration for surgery, the source mandates that the patient will be started on optimal medical therapy immediately.
Immediately, not waiting for surgery.
Not waiting. This isn't delayed until a surgical decision is made or surgery is performed. The medical therapy begins right away. We'll get into the specifics of optimal medical therapy, or OMT, in the next section. But just understand that patients in this high stenosis group receive immediate medical management alongside their surgical evaluation.
Okay. What if the stenosis is less than 70%?
Right. So if the answer to the first question, stenosis 70% or greater, is NO, we move to the next decision point regarding moderate stenosis. The protocol then asks, is the symptomatic ipsilateral stenosis between 50 and 69%?
50 to 69% and symptomatic. Key word there.
Symptomatic is key, yes, indicating that this moderate stenosis is considered the likely cause of the patient's Amaurosis Fugax symptoms. If the answer to this second question is yes,
Okay.
this patient is also considered a candidate for a carotid endarterectomy. However, the protocol highlights that the decision for surgery in this group is more nuanced than for the high-grade stenosis. It's based on an individual assessment.
More individualized here.
Exactly. Carefully weighing the potential benefits of surgery against the patient's specific risks, considering factors like their age and the presence and severity of their comorbidities, their other medical conditions. While surgery can be beneficial in this moderate stenosis range, the relative benefit compared to medical therapy alone is less pronounced than in the high-grade group, making patient-specific factors more influential in the shared decision-making process.
Makes sense. And OMT.
And just like the high-grade group, patients with symptomatic 50 to 69% stenosis will be started on optimal medical therapy immediately.
Immediately again. Okay. What if it's less than 50%?
Finally, if the answer to both of the above questions is NO, meaning the ipsilateral internal carotid artery stenosis is less than 50%, then the management pathway diverges significantly. The source states that this patient will be managed solely with optimal medical therapy.
OMT alone. No surgery considered.
Right. Surgical intervention, endarterectomy, is not indicated when the stenosis is less than 50%, as the risk reduction benefit doesn't outweigh the surgical risks. Importantly, the protocol emphasizes that in these cases where significant carotid stenosis is not identified as the likely cause, further investigation for alternative causes like cardioembolic sources, atrial fibrillation, other cardiac issues, or inflammatory causes like GCA should be pursued aggressively.
So finding low stenosis doesn't end the hunt.
Not at all. It underscores a crucial point. Finding minimal carotid disease doesn't close the diagnostic process. It redirects the focus towards the other potential etiologies that were screened for in the initial urgent workup, but might require more in-depth investigation if the carotid isn't the culprit.
So the carotid ultrasound result acts as the primary branching point in the management pathway. High-grade stenosis points strongly toward surgery plus immediate OMT. Moderate symptomatic stenosis still prompts surgical consideration based on the individual, plus immediate OMT. And minimal stenosis shifts the focus entirely to immediate OMT and aggressive investigation of non-carotid causes.
That sums it up well. So to quickly recap Section 4, the management pathway hinges on the degree of ipsilateral carotid stenosis found on duplex ultrasound. For stenosis, 70% or greater, carotid endarterectomy is considered, and OMT is started immediately. For symptomatic stenosis between 50 and 69%, endarterectomy is considered based on individual assessment, and OMT is started immediately. For stenosis less than 50%, management is OMT alone, with an emphasis on aggressively investigating other potential causes like cardioembolic sources or GCA.
Okay, Section 5 then goes into detail about optimal medical therapy, or OMT. The source makes a very important statement up front about who receives this critical component of care.
Yes, this is really a foundational principle of the protocol's management. It states unequivocally that all patients, regardless of the specific management pathway they are on based on their carotid findings, whether they are candidates for surgery or being managed medically, should receive optimal medical therapy unless there is a specific contraindication.
Unless there's a reason not to.
Right. A specific reason that prevents them from safely taking a particular medication or making a specific lifestyle change. But this means OMT is a near universal mandatory component of care for virtually every patient entering this pathway.
What are the key components, the pillars of this optimal medical therapy as precisely described in the source document? What does it actually involve?
Okay, there are four main areas that constitute OMT within this protocol, and the source highlights specific aspects, noting some as updates.
Four pillars, okay.
First is antiplatelet therapy. The
Mhm.
protocol specifies initiating dual antiplatelet therapy.
Dual, two agents.
Yes, using two different medications that inhibit platelet aggregation. The specific agents listed are aspirin and clopidogrel. Now, the source notes that this dual therapy is for a short duration following the acute event of amaurosis fugax.
Short duration only.
Yes, it provides examples for this duration, like 21 to 90 days. After this defined short period, the patient is transitioned to long-term single antiplatelet agent monotherapy.
So start with two, then drop to one.
Exactly. And this is a significant detail. The source explicitly states about this approach, this modifies the original regimen. This suggests that this protocol incorporates findings, likely from recent clinical trials in TIA and minor stroke, showing that a short period of dual antiplatelet therapy right after a transient event provides superior early protection against recurrent events compared to single therapy alone before you switch to long-term maintenance with a single agent.
Okay, that's a key update then. What's the second pillar?
Second is lipid-lowering therapy. This component involves initiating high-intensity statin therapy.
High intensity, not just any statin.
Right. The source goes beyond simply recommending statins. It specifies high intensity and gives concrete examples of the required regimens. Atorvastatin at a daily dose of 40 to 80 milligrams, or rosuvastatin at a daily dose of 20 to 40 milligrams.
Specific doses.
Yes. The explicitly stated goal here is to target a significant reduction in LDL cholesterol levels. This aligns with overwhelming evidence from cardiovascular prevention trials showing that more aggressive LDL lowering, particularly with high-intensity statins, provides substantial reduction in the risk of stroke and other vascular events, even in patients who might not have severely elevated baseline cholesterol.
And this is also noted as an update.
Yes. The source also notes regarding this component, this is an update to the originally suggested statin therapy, reinforcing that this protocol adopts current, more aggressive recommendations for lipid management in patients with recent ischemic events.
Got it. Third pillar.
Third is blood pressure control. The source mandates implementing optimal blood pressure control to achieve guideline-directed targets.
Guideline targets. Does it give numbers?
Not in this excerpt, no. But the emphasis is on adhering to established clinical guidelines for managing hypertension in patients with cerebrovascular disease. Controlling blood pressure is just a fundamental modifiable risk factor, crucial for preventing recurrent stroke and progression of underlying vascular disease.
Okay. And the fourth pillar.
Fourth is lifestyle modification. This essential component involves aggressively encouraging key behavioral changes to reduce vascular risk. This includes paramount advice like smoking cessation. Huge. Smoking is a major contributor to atherosclerosis and stroke risk. It also involves providing comprehensive guidance on diet, promoting a heart-healthy pattern, regular exercise, and for patients with diabetes, optimizing their diabetes management to recommended targets. These lifestyle changes are really foundational to secondary prevention and complement the pharmacologic therapies by addressing underlying systemic risk factors. Okay, so to quickly recap Section 5 on optimal medical therapy, or OMT. It's a mandatory component for virtually all patients under this protocol unless contraindicated. It consists of four main pillars. First, antiplatelet therapy, initiated as dual therapy with aspirin and clopidogrel for a short duration, like 21 to 90 days, followed by long-term single therapy, noting this as an update. Second, high-intensity statin therapy using regimens like atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams, targeting significant LDL reduction, also highlighted as an update. Third, achieving optimal blood pressure control according to guidelines. And fourth, aggressive lifestyle modification, including smoking cessation, diet, exercise, and optimal diabetes management.
Let's synthesize what we've learned about the management and therapy pathways outlined in Sections 4 and 5. This is the core treatment block.
Right.
After the initial ophthalmologist diagnosis and the urgent same-day workup, the management pathway is primarily dictated by the degree of ipsilateral carotid artery stenosis found on the duplex ultrasound.
Driven by the ultrasound.
If high-grade stenosis, 70% or greater, is present, the patient is considered for carotid endarterectomy.
Huh.
And critically, optimal medical therapy is started immediately.
Surgery consult plus immediate OMT.
If symptomatic moderate stenosis 50 to 69% is found, endarterectomy is also considered, but the decision is individualized based on patient factors, and OMT is started immediately.
Individualized surgery consult plus immediate OMT.
If the stenosis is less than 50%, the patient is managed solely with OMT, and the protocol directs an aggressive investigation of alternative causes like cardioembolic sources or giant cell arteritis.
OMT only, plus hunt for other causes.
And across all these pathways, optimal medical therapy is a universal requirement, unless contraindicated, forming the cornerstone of secondary prevention. OMT itself, as detailed in Section 5, includes specific updated approaches. Short-term dual antiplatelet therapy, followed by long-term single therapy, high-intensity statin therapy targeting aggressive LDL reduction, guideline-directed blood pressure control, and aggressive lifestyle modification. These sections together provide a clear, tailored approach to intervention and risk factor management based on the diagnostic findings.
All right, let's test our understanding of the management approach with another clinical scenario, bringing together concepts from sections 4 and 5.
Okay, another board-style question.
A 70-year-old patient presents with recent, repeated episodes of transient vision loss in their right eye. Carotid duplex ultrasound reveals an 80% stenosis of the right internal carotid artery. ECG is normal. Inflammatory markers are normal. According to the protocol described in sections 4 and 5, which of the following is the most appropriate immediate management plan?
A. Initiate long-term single antiplatelet therapy and schedule surgical review in 1 month. B. Start dual antiplatelet therapy with aspirin and clopidogrel, high-intensity statin, optimize blood pressure, and refer urgently for surgical consideration. C. Start high-intensity statin and await surgical clearance before initiating antiplatelet therapy. D. Manage only with aggressive lifestyle modifications since the ECG was normal. Short pause.
Okay, let's break this down. The patient has symptomatic transient vision loss and an 80% ipsilateral carotid stenosis.
High-grade stenosis.
High grade, exactly. According to Section 4, stenosis 70% or greater means the patient is a candidate for carotid endarterectomy and must be started on optimal medical therapy immediately.
Immediate OMT is key.
Section 5 details OMT, which includes initiating dual antiplatelet therapy with aspirin and clopidogrel for a short-term, high-intensity statin therapy, blood pressure control, and lifestyle modification. So looking at the options, option A is incorrect because it suggests single antiplatelet therapy initially and delays the surgical review.
Wrong on both counts.
Option C is incorrect because it delays antiplatelet therapy pending surgical clearance and doesn't mention all components of OMT. We know OMT starts immediately.
Can't wait on the meds.
Option D is incorrect as it ignores the significant stenosis and the mandated OMT. The normal ECG doesn't change the need for carotid management.
Definitely not D.
Option B correctly combines initiating the full optimal medical therapy regimen, immediately dual antiplatelets, high-intensity statin, optimized blood pressure with urgent referral for surgical consideration based on the high-grade stenosis. That fits perfectly. The correct answer is B.
Correct. B is the answer that follows the protocol directly. Okay, Section 6 turns our attention to a critical aspect often necessary for complex cases like Amaurosis Fugax, multidisciplinary team, or MDT, collaboration. The protocol recognizes that effectively managing these patients requires expertise and coordination across several medical specialties.
That's a key takeaway. It's not just one specialist's responsibility. The source highlights specific consultations that are integral to this integrated approach. Who needs to be involved?
Yes, it names key specialties and the clinical triggers for involving them in the patient's care pathway. First, neurology. Consultation with a neurologist should be considered for any patient managed under this protocol who presents with atypical features in their Amaurosis Fugax episode. If there is persistent diagnostic uncertainty even after the initial urgent workup, or if they had concurrent neurological symptoms alongside the vision loss.
Like the hemiparesis or dysphagia we talked about earlier.
Exactly. Those symptoms which trigger brain imaging. What's particularly notable is the source clarifies that this consultation is needed not only for patients experiencing recurring symptoms.
So even for a single complex event.
Right. This suggests a relatively low threshold for involving neurology when the clinical picture is complex, doesn't fit the classic mold, or involves broader concerns beyond isolated ophthalmic ischemia, allowing for expert neurological assessment of the overall TIA risk and potential underlying central nervous system issues.
Okay, well.
Second, cardiology. Consultation with a cardiologist is recommended for patients who had an abnormal 12-lead ECG as part of their initial urgent workup, or if there's a strong clinical suspicion for an underlying cardiac arrhythmia, maybe like paroxysmal atrial fibrillation, which might not show up on a single ECG.
Makes sense for the cardiac sources.
Yes. Furthermore, and this ties back directly to Section 4, cardiology consultation is recommended specifically in cases where no significant carotid stenosis is found.
Right. If the carotids are clean, look harder at the heart.
Exactly. If the carotid scan is normal or shows minimal disease, the search for the etiology aggressively pivots towards other sources, and a cardiac source becomes highly probable. Cardiology input is then essential for further investigation, which might include prolonged cardiac monitoring, like a 24-hour Holter or even longer event recorders, and other tests to identify a potential source of cardioembolism, think valvular heart disease or structural abnormalities that could be causing the transient visual events.
Okay. Neurology, cardiology, anyone else mention?
Third, specifically within the context of vascular surgery referral for potential endarterectomy, the source names a specific individual who plays a coordinating role, Dr. Gregory Weir.
Ah, a named contact.
Yes. It states that Dr. Gregory Weir will coordinate the required special investigations and specialist consultations. This indicates a designated point person or service responsible for ensuring that patients who are candidates for surgical assessment or who require complex multidisciplinary input navigate the necessary diagnostic steps like specialized imaging or tests and receive timely consultations with the relevant specialists, including cardiology, neurology, and the vascular surgery team itself. This coordination is vital for the efficiency and effectiveness of this rapid response pathway. Okay, so in summary of Section 6, the protocol emphasizes a multidisciplinary team approach. It recommends consulting neurology for atypical presentations, diagnostic uncertainty, or concurrent neurological symptoms. Explicitly stated, this isn't limited to recurring symptoms. Cardiology consultation is recommended for patients with abnormal ECGs, suspected cardiac arrhythmias, or when no significant carotid stenosis is found, focusing the investigation on cardioembolic sources. The protocol names Dr. Gregory Weir as the coordinator responsible for arranging required special investigations and specialist consultations, ensuring streamlined patient management within this complex pathway.
Section 7 focuses on a crucial part of any management protocol, follow-up. The document outlines a structured approach that differs depending on how the patient was ultimately managed medically versus surgically, and also details how communication with the referring ophthalmologist is handled.
Yes, the follow-up schedules are tailored to the patient's specific management pathway to ensure appropriate monitoring for medically managed patients.
So the ones who didn't have surgery, mainly less than 50% stenosis.
Right, primarily those with less than 50% stenosis, or perhaps those with moderate stenosis where surgery wasn't pursued after individual assessment. The protocol specifies that a repeat carotid duplex Doppler scan will be performed after 6 months.
6-month repeat scan.
Yes. This repeat scan serves as a check to monitor for any potential progression of minimal stenosis, or just to reevaluate the carotid arteries down the line. But the source includes a critical safety clause here. An earlier repeat scan will be arranged if symptoms recur.
Yeah. Important safety net.
Very important. If transient vision loss episodes return before the scheduled 6-month follow-up, it indicates potential ongoing or new issues that warrant urgent reinvestigation, overriding the standard schedule.
Okay. What about the post-surgical patients?
For post-surgical patients, those who undergo a carotid endarterectomy for significant stenosis follow-up is structured according to standard postoperative protocols. The source lists a typical schedule for this surgical surveillance. An initial check at 2 weeks following the operation.
2 weeks?
A subsequent visit at 6 weeks post-operation.
6 weeks?
Another at 6 months post-operation.
6 months.
And then annual follow-up thereafter. This schedule allows for monitoring of surgical wound healing, assessment of any immediate postoperative complications, and importantly, often includes repeat imaging, like duplex ultrasound, at intervals, particularly at 6 months and annually, to check for the possibility of restenosis, where the artery narrowing recurs at the site of the surgery.
Okay, standard surgical follow-up. What about the referring doc?
Right. The protocol explicitly addresses communication and follow-up with the referring ophthalmologist. This is vital because they initiated the pathway.
Closing the loop.
Exactly. The source states that telephonic feedback will be provided to the referring ophthalmologist. This ensures prompt communication regarding the findings of the urgent workup, the management decisions made, and the plan moving forward. Furthermore, upon the patient's discharge from the acute phase of management within this coordinated pathway, whether from hospital or from the intense outpatient workup, a follow-up assessment with the referring ophthalmologist will be arranged for the patient.
So the patient goes back to see their eye doctor too?
Yes. This closes the loop, ensuring the original referring physician is informed of the outcome and that the patient has a planned return visit to the ophthalmic setting to continue their ongoing eye care, integrated with the vascular and neurological management they received.
Okay, just recapping Section 7 on follow-up. Medically managed patients get a repeat carotid duplex at 6 months, or sooner if symptoms recur. Post-surgical patients follow a standard schedule at 2 weeks, 6 weeks, 6 months, and annually. And importantly, the referring ophthalmologist receives telephonic feedback and the patient gets a follow-up arranged with them upon discharge.
Right. The final section, Section 8, delves into the very practical, operational aspects of the protocol, referral logistics and data management. The source frames this within the context of a memorandum of understanding, highlighting it as an agreed-upon framework for how this specific protocol is implemented in practice. These details are fundamental to making the protocol work effectively on the ground, ensuring patients are referred correctly, tests are done promptly in the right place, and outcomes are tracked.
The nuts and bolts. These details are crucial for making the protocol work on the ground. What does the source tell us here?
They provide the necessary infrastructure for the clinical pathway. This section details specific contact information, designated locations for urgent tests, criteria for hospital admission, and how patient data is collected and utilized. First, the designated referral contact.
Who do you call?
For any patient diagnosed with Amaurosis Fugax by an ophthalmologist who needs to be referred into this urgent management pathway, Dr. Gregory Weir is listed as the central contact person. The source provides his specific contact details. His room's phone number, 012-335-8651.
Okay, 012-335-8651.
And his cell phone number, 082-498-2652.
082-498-2652.
Got it. Central contact.
Yes, this centralizes the initial point of contact, allowing for efficient initiation of the protocol and coordination by Dr. Weir, as mentioned in Section 6. Second, the specified location of investigations.
Where do the tests happen? To ensure that crucial urgent duplex Doppler scans are performed rapidly, the protocol standardizes their location. It specifies that these urgent scans will be performed at Life Eugene Moraes Hospital and explicitly on the same day as requested.
Same day, specific hospital. Okay.
Having a designated location likely streamlines the booking and performance of these time-sensitive studies within that specific hospital's radiology or vascular lab department. Third, hospital admission.
When would someone need to be admitted?
The protocol addresses practical barriers patients might face in accessing the urgent multidisciplinary workup. It states that patients who have significant transport difficulties or other logistical problems that would impede their ability to complete the necessary urgent investigations on an outpatient basis will be offered admission to hospital.
For logistical reasons.
Exactly. The source clarifies that this option is especially relevant if a comprehensive workup is required, including potentially a 24-hour Holter ECG and other cardiac, neurological, and radiological investigations. Hospitalization allows for rapid sequencing and completion of multiple tests and consultations with various specialists within a controlled environment, overcoming geographical distance or coordination challenges that might delay the urgent assessment if attempted solely on an outpatient basis.
Makes sense for complex cases or patients far away. What about data?
Fourth, the database. The protocol includes a clear commitment to systematically collecting information on the patients managed within this framework. It states that all patients managed under this protocol will be entered into a prospective database.
Tracking everyone.
Yes. A prospective database involves collecting data moving forward from the point of diagnosis or entry into the protocol. This is essential for monitoring patient characteristics, risk factors, the investigations performed, the treatments administered, medical and surgical, and importantly, clinical outcomes like recurrent amaurosis fugax, stroke, or other vascular events.
And
Fifth, data sharing. The protocol outlines how the data collected in this database will be used, indicating a commitment to review and improvement. It specifies that anonymized data, meaning patient identifiers are removed to protect privacy, will be supplied to the Pretoria Eye Institute on a regular basis.
Anonymized data shared. Why?
The purpose is stated as facilitating review and collaboration. Sharing anonymized data with an academic or research institution like the Pretoria Eye Institute allows for clinical audits, evaluation of the protocol's effectiveness in a real-world setting, identification of areas for potential improvement, and contribution to broader research understanding of Amaurosis Fugax management outcomes. It signifies a feedback loop for continuous quality improvement based on collected data.
And finally, a quick recap of Section 8. Referral logistics and data management. This provides the practical blueprint for the protocol's operation. It designates Dr. Gregory Weir as the central contact for referrals, providing specific phone numbers. Rooms 012-335-8651, cell 0824982652. It standardizes the location for urgent duplex scans to Life Eugene Moraes Hospital, performed on the same day. It offers hospital admission to patients with significant logistical barriers, especially if a complex, urgent, multidisciplinary workup is needed. It mandates entry of all patients into a prospective database for tracking outcomes. And it ensures anonymized data from this database is shared regularly with the Pretoria Eye Institute for ongoing review and collaboration, supporting evaluation and potential refinement of the protocol.
Okay, let's bring together the details from sections 6, 7, and 8, covering multidisciplinary collaboration, follow-up, and logistics. This is the how it works part.
Yeah, the implementation block. Mega recap time.
So, the protocol emphasizes a team-based approach involving consultation with neurology for complex cases, cardiology for suspected cardiac sources, and designates a coordinator, Dr. Gregory Weir, for managing investigations and referrals. Follow-up varies based on management. Medically treated patients have a repeat carotid scan at 6 months or sooner if symptoms recur, while post-surgical patients follow a standard schedule at 2 weeks, 6 weeks, 6 months, and annually. Communication back to the referring ophthalmologist is a priority, with telephonic feedback and arranged follow-up appointments. Logistically, the protocol provides specific contact information and locations for urgent scans, offers hospital admission to overcome transport or logistical barriers for complex urgent workups, and mandates entry of all patients into a prospective database with anonymized data shared with the Pretoria Eye Institute for ongoing review and collaboration.
Okay, time for one final scenario to tie things together, pulling from these later sections.
Let's do it.
A 45-year-old patient presents with a single resolved episode of Amaurosis Fugax in the left eye. Initial workup shows no significant carotid stenosis, normal inflammatory markers, but the 12-lead ECG shows premature atrial contractions. They live 2 hours away and have difficulty arranging multiple specialist appointments quickly. According to the protocol described, which course of action aligns best with the recommendations in sections 6 through 8?
A. Manage with optimal medical therapy and schedule a repeat carotid ultrasound in 6 months. B. Offer hospital admission for a comprehensive cardiac, neurological, and radiological workup and arrange consultation with cardiology. C. Schedule non-urgent consultations with cardiology and neurology as outpatient appointments. D. Focus solely on lifestyle modification as carotid stenosis was not found. Short pause.
Okay, let's evaluate the options based on the protocol. We have Amaurosis Fugax confirmed. Initial workup ruled out significant carotid disease and GCA. Patient is under 50 anyway, but markers normal. But we have an abnormal ECG finding PACs raising suspicion for a potential cardiac source, even if not definitive atrial fibrillation yet.
All right, the ECG isn't normal.
And the patient has logistical challenges. Section 4 states that if stenosis is less than 50%, further investigation for alternative etiologies like cardioembolic sources should be pursued aggressively.
Aggressive investigation needed.
Section 6 recommends cardiology consultation for abnormal ECGs or suspected arrhythmias, especially when carotid disease isn't the cause. Section 8 specifically addresses patients with transport or logistical problems, offering hospital admission, especially if a comprehensive workup including cardiac, neurological, and radiological studies is required.
Which seems needed here, given the ECG and the need for aggressive investigation.
Exactly. Option A is incorrect because while OMT is indicated, simply scheduling a repeat carotid ultrasound doesn't aggressively pursue the likely cardiac cause or address the logistical issues.
Not aggressive enough.
Option C ignores the urgency potentially needed for the cardiac workup and definitely ignores the logistical barrier that hospital admission could solve.
Doesn't solve the transport problem.
Option D is insufficient. Aggressive investigation is needed, not just lifestyle changes, especially with an ECG finding.
Can't just rely on lifestyle.
Option B directly addresses the need for aggressive investigation of a possible cardiac source, cardiology consultation, and the logistical challenge by offering hospital admission to facilitate the necessary urgent comprehensive workup as described in Section 8. This allows for potentially more involved cardiac monitoring and other tests rapidly. The correct answer is B.
B it is. Okay, well, that was a truly deep dive into the Amaurosis Fugax Management Protocol 2025. We've walked step by step through this structured approach, from the crucial initial diagnosis by the ophthalmologist that triggers the process, through the mandated urgent diagnostic workup, including imaging criteria, understanding how the clinical management pathways diverge based on carotid stenosis findings, detailing the specific components and highlighted updates within the essential optimal medical therapy, emphasizing the vital role of multidisciplinary team collaboration, outlining the tailored follow-up schedules, and finally, exploring the practical nuts and bolts of referral logistics, contact points, and the commitment to data management and review.
Yeah, this protocol, as presented in the source document, provides a really clear, comprehensive, and evidence-informed framework specifically designed to standardize the approach to patients presenting with amaurosis fugax. It underscores the absolute necessity of urgency in diagnosis and initial workup, ensures comprehensive investigation of the most likely underlying causes, primarily carotid and cardiac,
Right.
incorporates specific updated recommendations for medical therapy regimens reflecting current evidence, and establishes clear pathways for multidisciplinary collaboration and practical implementation. The overarching goal is to provide a structured, timely, and tailored approach aimed at significantly reducing the patient's risk of a future, potentially devastating cerebral stroke and permanent vision loss.
It really does lay out a concrete step-by-step pathway, providing clarity in a scenario that demands rapid, decisive action. So, stepping back now, what does internalizing the details of this specific protocol, as outlined in the source, mean for you, the clinician, in your own practice when that patient with transient vision loss sits in front of you?
Well, I think it reinforces the critical importance of not dismissing transient visual symptoms. It means having a high index of suspicion for underlying vascular or cardiac disease. And once amaurosis fugax is suspected or diagnosed by the ophthalmologist, having a low threshold for initiating this specific, urgent, comprehensive workup covering carotid imaging, mandatory ECG, and inflammatory markers when indicated, all preferably on the same day.
That same-day urgency again.
Exactly. It means understanding which findings from that initial workup direct the patient down which specific management pathway towards surgical consideration or medical therapy alone, and immediately initiating the detailed optimal medical therapy regimen described, including the updated approaches to antiplatelets and statins.
Know the OMT updates.
Yes. It requires knowing exactly when and how to engage the multidisciplinary team, neurology, cardiology, vascular surgery, and understanding the logistical framework for referrals and urgent investigations within the system this protocol operates in. Ultimately, it's about embedding this structured, urgent, and comprehensive approach into your standard clinical practice when faced with a patient presenting with this critical warning sign.
A comprehensive, systematic approach built on rapid evaluation and tailored management.
Absolutely. And it leaves you with a final provocative thought. Considering the specific updates and recommended medical therapy regimens outlined in this 2025 protocol, like the nuances of dual antiplatelet therapy duration and the emphasis on high-intensity statins, and reflecting on the structured multidisciplinary team approach and defined logistical pathways, how might the consistent application of this particular protocol, as described in the source, potentially impact and improve the aggregate outcomes for stroke prevention, specifically in patients presenting with amaurosis fugax within your own clinical environment over the coming years? And what valuable insights might the prospective database mentioned in Section 8 ultimately reveal about the real-world effectiveness of this standardized pathway? It prompts you to consider not just the management of the individual patient, but the broader impact and evaluation of implementing a defined, evidence-based protocol.